Okay. So let's talk a little bit about complications. We'll talk about biceps tears, paralabral cysts, and neurologic changes. So let's see, Robert, what do you think about this?
Let's see. It looks like there's a tear of the superior labrum,
Yeah.
and then
Now,
looks also
how do you know this is a tear and not a superior recess?
looks like it's going away from the articular surface a little bit there, where yeah.
Way a little bit there. And then we also see there's a little perimeniscal cyst here, which you shouldn't get in a normal recess. So that also supports that this is a tear and not just a normal recess. So I actually find the sagittal images important. And I usually start looking at the shoulder, looking at the sagittal images myself, and just to kind of go over that anatomy for you. Here's the pectoralis major muscle in front, minor behind it, serratus anterior behind the minor, subscap, supra, trap, deltoid, teres minor down here, all that. And then the triceps long head, it comes off that inferior most margin of the glenoid, comes posteriorly underneath the infraspinatus back here. Teres major is underneath that long head of the triceps. And then the latissimus, and it goes a little bit more horizontal, and then going down is the latissimus dorsi here. Okay, now there are two areas that are important also anatomically. There's a suprascapular notch and the spinoglenoid notch. I spent most of my life trying to remember these names. For some reason, I could never remember them. So the suprascapular notch is what the suprascapular nerves come in. It first goes through the suprascapular area, then it goes inferiorly to the spinoglenoid notch in here, and that direction is actually important, as we'll talk about in a minute. And the vessels go along with it here. And primarily, if you have a mass like a paralabral cyst, which dissects into the suprascapular notch up here, and if it compresses the suprascapular nerve in this location, then it will affect the innervation of both the supraspinatus and the superior aspect of the infraspinatus muscles. Therefore, suprascapular cysts tend to involve both muscles. If it goes more inferiorly into the spinoglenoid notch, then it will not affect the suprascapular, it'll just affect the infraspinatus muscle. So here's the nerves and vessels going into the suprascapular notch up here. This is anteriorly. Here is in the notch itself, right in through here, the vessels and the nerve. The quadrilateral spaces underneath, and then farther back and down a little, well, actually we're getting down to the spinoglenoid notch here. This is a little bit anterior to the suprascapular notch. So those are the suprascapular nerves, which affects the supraspinatus and the superior two-thirds of the infraspinatus, and the actual line of demarcation varies a bit from person to person. And then the axillary nerve goes down through the quadrilateral space in through here, extends posteriorly, and that innervates the teres minor and sometimes the inferior aspect of the infraspinatus muscles back there. So I don't think we need to go through the details of all this here. But basically, here's the suprascapular nerve coming across here, down into the suprascapular notch, spinoglenoid notch, then out into the muscles here. So not cysts are not rare. They typically arise from torn labral cysts, and the more superior ones and anterior ones tend to involve the suprascapular notch, and the more posterior inferior ones, the spinoglenoid notch, and they can extend and dissect out into the soft tissues where they can compress the nerves, and this can then lead to otherwise unexplained rotator cuff weakness, which often was difficult in the past. But with MR, we can see both the cyst and we can see changes to the muscles, which help us a lot. So typically when you have this denervation of the muscles, the margins of the edema or atrophy, if it's acute, it's edema. If it's chronic, it's more atrophy. The margins are usually well defined. And the suprascapular notch involves both muscles, as we say, spinoglenoid notch, just the infraspinatus. So this is where the cyst would be, and here you can see it compressing the nerve. Okay.
Do you want about the treatment, John, or?
Yes, go ahead. Tell us about the treatment.
Um, well, if it's a cyst, what you do is arthroscopically aspirate the cyst, makes it easier to remove. And the main thing is you have to repair the glenoid labrum
Labral tear.
if it's in that area. Otherwise, if it's some suprascapular area, then you just decompress it and remove it.
Good. Thank you.
So you probably get 100% return of function if it's within a reasonable time.
Thank you.
All right, so looking at the superior labrum, looks frayed and probably torn with a paralabral cyst projecting into the spinal glenoid notch.
Yep.
Yeah. And then looks like there is supra and infra look okay in terms of volume, I think.
What about the signal intensity of the supra versus the other muscles?
There is increased signal intensity diffusely.
Okay.
Yeah.
What about that's the supra? What about the infra?
I think the infra there is, yeah, I don't think it looks too terrible. There's same signal as the supra, but there's no like volume loss or any fatty stripping in there.
So this is actually up pretty high here.
Yeah.
So this is actually affecting the suprascapular notch. And you can see this is the typical appearance of acute denervation edema within the supraspinatus muscle. And if you notice over here, the superior two-thirds of the infraspinatus muscle on this T2 weighted sagittal image is also edematous, whereas the inferior third or quarter looks like the other muscles around it. So this is actually may extend down a little bit into the spinoglenoid notch here, but this is high. This is almost kind of a little bit in between, but functionally it's in the suprascapular notch,
Okay.
and it's really affecting the innervation to both of the muscles.
Okay.
Now, when you see,
But the cause of the cyst, though, is the labrum tear, and that is a slap lesion, I think, isn't it, John?
yes, I don't show that here. I'm just trying to
And
show
so,
the muscles.
yeah,
But you're
so you
absolutely
have,
correct. This patient had a superior slap tear.
so you have to either decompress it or repair it.
Right, right. Okay.
This patient looks young enough to repair.
Right. I agree with you. Now, so this is edema within the muscle. Typically, if you have a cyst here, the primary symptom is weakness, but you can also have pain. There's another condition that we'll talk about probably in the future lectures, where you get edema within the muscles, but the symptoms are primarily just pain, but you can also get weakness where you don't have these cysts, and that's called Parsons-Turner syndrome. but I think we'll talk about that in another lectures. But those are the two things that you can, well, if you see muscle, if you see the edema that kind of completely involves the muscle and is sharply defined here, involving the superior aspect of the infraspinatus, this is really very characteristic of a denervation type change. If you have a tear of the muscle, it's usually not complete like this, and it's usually inhomogeneous, and it really, if you've seen a lot of tears, it just has a different appearance if it's a muscle strain than a denervation. And the Parsons Turner looks just like this, except you don't have the cysts. And then we'll talk when we get to that about the etiology. It could be vascular, it's probably neuro, could be muscle strains, but the thing to know is if it's a Parsons-Turner syndrome and you don't have a cyst like this, the prognosis is very good with conservative management. Whereas in this kind of situation, you typically want to go in and relieve the pressure on the nerve.
Okay, so here we see a posterior labral tear with medial paralabral cysts. Probably,
Where did you say medial perinatal? What do you mean?
well, they're extending more medially,
Oh,
right?
I see. Medial from the
From the posterior labrum,
glenoid.
yeah.
Gotcha.
Yes.
Right.
And some increased signal within the infraspinatus muscle.
Okay. Yeah. So there's a little bit of increased signal. Notice there's a subtle difference in signal intensity. But the other thing that you can see is actually the infraspinatus is smaller than you might expect, considering the size of the other muscles. Okay. And then this was a chronic degenerative tear, the posterior superior labrum, and there's a cyst that's going into the spinoglenoid notch, and you can see it's down here lower than the prior one, and then on the coronal PD fat set, you can clearly see the difference between the involved muscle, the denervated muscle, and the normal muscle here, and that kind of sharp demarcation that you see kind of between the superior and the inferior thirds of the infraspinatus. So pretty classic. That's a spinal glenoid knot cyst.
So I believe we can see, I think there's a small cyst in the supraspinatus, or sorry, yeah, suprascapular notch right there.
Yeah. So you can see that this is actually a bit posterior to the supraspinatus.
Yeah.
And it's kind of in between the supraspinatus and the infraspinatus. So you'd want to look around, but this would be the posterior superior labrum, and it could dissect into the suprascapular notch, but usually when they're this far posterior, its tendency is to go more into the spinal glenoid notch. So we want to look at the muscles to really help us define that. Now this is an arthrogram. What do you think of the arthrogram?
So there's some contrast extravasating into that, but like posterior to the that posterior labrum, and
Wait, are you talking about this?
sorry, anteriorly.
Up here?
Yeah,
Okay, what's that from?
that might just be the recess actually,
This
or
is
that
probably,
might be from the. It could be from a tear.
this is probably from the injection,
Oh, okay,
because we typically do an anterior injection through here.
okay.
So what else do you see?
So at that posterior labrum, there's a tear there.
Okay, so we see a nice tear here, but here it looks like we see a cyst. So do you see the cyst?
No. Oh, I think the cyst can have some I think you were saying like kind of a gelatinous tech.
Okay, good. So this is a T1 weighted image. If we go to the T2 weighted image, this is
Okay.
what it looks like.
Oh wow. Yeah.
So again, this is a paralabral cyst, and it's a very large one going back into the spinoglenoid notch area. But again, it doesn't communicate robustly, and it's probably more gelatinous, so it takes a long time for the contrast to diffuse into it. So another reason you always have to do T2 weighted images, I think, in imaging, though a lot of radiologists don't. And you can never get away with just fat suppressed images, as we've said over and over again in these lectures. Yeah, so there's the cyst, and it's poorly communicating. Okay, and there we can see it here. And then here's another example where we can see poorly communicating cysts with just a little bit of contrast going out into them on the arthrogram. Okay, Robert.
All right, so we have a 46-year-old male shot in the left while wearing a bulletproof Kevlar jacket. See any bullets, but that left scapula looks like it's very elevated relative to the right.
So the Kevlar jacket keeps the bullets out, but it doesn't stop necessarily the impaction to the body that a bullet can impart. So what do you think's going on here?
I mean, I think there's been substantial trauma to that left shoulder that's causing that. I guess I don't know what the appropriate term is for
This is a
dislocated
this is a winged scapula.
wing scapula.
So this scapula is no longer in the proper position here. As you can see, it's really tilted. So this part of the normal side is now way up here. And so the scapula is now no longer positioned appropriately by the scapular muscles, right? And then here it's superiorly migrated and rotated. And here you can see the acromion process and how the scapula, instead of being down here where it's supposed to be, has rotated up there, about ready to take flight. So this is called scapulothoracic dislocation in this patient due to the impaction of the bullet, though you don't see a bullet because the Kevlar kept the bullet out, but not the traumatic injury. So let's go on and talk a little bit about the quadrilateral space. It's also called the quadrangular space. And it's named because it's kind of a rectangular form along the borders. So inferiorly, it's the teres major muscle. Superiorly, it's the teres minor. Medially, it's the long head of the triceps tendon. And laterally, it's the medial side of the humeral neck. And it's this area right in through here. And this is where the axillary nerve and vessels go through. You get the quadrilateral space syndrome, which is typically due to compression of the axillary nerve and the posterior circumflex artery in this particular space by fibrous bands, by paralabral cysts with inferior labral tears, and very rarely with tumors and hematomas. Now, it's quite common for us to see isolated atrophy of the teres minor muscle, which you guys have seen a lot, I'm sure, already. And often by the time we see fatty atrophy, whatever caused it is long gone, probably years before. But it probably has something to do with something affecting the axillary nerve in the quadrilateral space. And my guess is that many of these are athletes. Many of these probably had inferior labral tears at one time that probably spontaneously kind of healed over time, and they had compression of the nerve. But once you get severe atrophy of a muscle caused by nerve damage, you really can't get the muscle back again. It's kind of an irreversible thing. And then rarely get tumors and hematomas. If you're lucky enough to catch it in the acute phase where you just have edema and not fatty atrophy, then by decompressing it, you can save the muscle. And as you know, we've seen some very high-level athletes with isolated atrophy of the teres minor muscle who are still able to be Major League Baseball pitchers. So because there's so many muscles in this area, it is something that doesn't necessarily have to have significant functional deficits. Clinical symptoms, often in young adult athletes, you get kind of pain posterolaterally. Intermittent dull pain is something that athletes get all the time, kind of everywhere, so it's often not considered significant until long after the irreversible changes have occurred. And the pain tends to be in a non-dermatomal distribution, and generally they're not reliably diagnosed clinically. So what we look for is fatty atrophy of the teres minor muscle, but in the acute setting, you're really looking for the denervation findings before you have atrophy. And you can also get portions of the deltoid muscle because the posterior deltoid muscle can be innervated by the same nerve. And you look for edema within those two structures. Okay, so that's kind of the end of our instability. John, okay, let me just see here.
Yes.
Okay, I'm going to log out and log back in again, okay?
Okay.